Very good afternoon to all. I'm Dr. Vikendra Yadav, Additional Professor, Division of Periodontics, CDR. And on behalf of CDR, I thank you all for joining us this afternoon. The topic of our presentation is when seizure control costs a smile, the medication quality of life link, where we will be presenting a case of an adolescent girl who was undergoing treatment of epilepsy in the Department of Neurology. And you will see how the adverse effect of the drug severely affected or compromised the physical, mental, and the social health of the patient. And we will see how the case was managed by the most conservative means, of course, in collaboration with the Department of Neurology or the treating physician. So let's walk through the case. I would call upon Dr. Jaya to present the case.
Good afternoon, everyone. I'm starting with the case presentation. A 15-year-old female patient reported to the Department of Periodontics along with her mother. She was referred from the neurology department, AIIMS. She presented with the chief complaint of severely enlarged gums, pain on chewing, difficulty in closing her mouth, and anesthetic appearance. Her mother also reported that the patient has restricted social interaction and she was also missing her stool since her gums became this enlarged. History of presenting illness. She started noticing gingival growth 10 to 12 months back, and she has started developing severe pain on chewing food for the last 3 months. Because of that, she was not able to take solid food and she was exclusively on the soft diet. And she also reported of bad breath or halitosis because she was not able to maintain her oral hygiene or brush her teeth because of the pain and sheer enlargement of the gums. Her past medical history: 3 years ago, she had episodes of seizure for which she consulted to the neurology department. She was diagnosed with mesial temporal lobe epilepsy and she was started with phenytoin therapy, 150 mg twice daily. Since then, she had no seizures, no episodes of seizure, and good seizure control. She never sought any dental treatment or consultation prior to this visit, and she also has no history of familial gingival enlargement or growth. Her evaluation at the Department of Periodontics. On general examination, patient appeared weak and undernourished. Although she was conscious, oriented, and well cooperative, she also had compromised facial aesthetics. On her extraoral evaluation, the patient had asymmetric facial appearance because of the gingival enlargement. She had a protuberant gingival mass from her maxillary palatal region. Because of that, she was not able to close her mouth and her lips were also incompetent. Her intraoral examination revealed generalized severe gingival enlargement covering both her maxillary and mandibular arches. More than three-fourths of her coronal surfaces of teeth were covered with the soft tissue, and in few areas, her teeth were completely embedded in the soft tissue as well. On examination, the soft tissue was lobulated in appearance. It was erythematous, it was tender on palpation, and it bled easily on probing. There was also generalized plaque and calculus because of the poor oral hygiene. And because of this growth from her palatal region, there was a pathological migration or the buccal displacement of maxillary central incisors. On maxillary and mandibular view, we can appreciate that the growth was such massive that it was extending and covering almost her entire palatal area and also the lingual tissues as well. Her periodontal parameters revealed that she had 82% of plaque, bleeding also present. There were pseudo pockets because of the enlargement, and she had severe growth with the maximum score on gingival overgrowth index. Patient was advised to get radiographic investigations, blood investigations, and histopathological investigations done. Her radiographic assessment showed that there was displacement of maxillary anterior incisors, and the rest of the anatomy of the alveolar bone and teeth were fine. And her blood workup was also fine within normal limits. To confirm the diagnosis, an incisional biopsy was carried out from the right maxillary canine region, and her histopathology revealed that she had elongated retipex with long extensions, loose collagen bundles with numerous budding capillaries. So based on her clinical presentation, her past medical history, her history of taking drug, the definitive diagnosis was made, which is phenytoin influenced gingival enlargement. Although it was superimposed with the inflammatory component as well, because she was not able to maintain her oral hygiene. I would like to invite Dr. Anika ma'am to take up the treatment.
Good afternoon. For the treatment management, we basically focused on two aspects. One was the non-surgical periodontal treatment and one was the drug substitution. So as shown by Dr. Jaya, the enlargement was so massive and so disfiguring that patient was not able to brush. So initially, in order to control the microbial load and improve the periodontal inflammation, the patients was first instructed to start with anti-plaque rinses, which was the chlorhexidine digluconate. And also patient was instructed that she should follow oral swabbing. That is, she was advised that she should dip a pellet of cotton in the chlorhexidine mouthwash and swab her gingiva as well as whatever tooth was visible, so to control the plaque level. So the first set of management was targeted towards controlling the plaque levels and instructing about oral hygiene. As the inflammation would settle, then she was advised that she could start using an ultra soft toothbrush and a small toothbrush gently on her teeth surface. In conjugation with that, we gave a referral to the neurology department and for asking for reduction of dosage or a drug substitution as admissible. So drug substitution was advised as initially patient was on phenytoin 300 mg and now it was substituted with the newer anti-epileptic drugs, that is levetiracetam and oxycarbamazepine, together with an adjunctive folic acid supplementation. So for the follow-up, so this was a basic baseline photo, and even in the first month of the advising and starting with the non-surgical periodontal therapy, starting with anti-plaque measures and followed by scaling and removing of plaque and calculus deposit, within 1 month of this synergism, we were able to see that there was a large portion of regression of gingival enlargement which took place, especially appreciable on the buccal aspect. Also, on the other, if that can be appreciated on from the lateral views also, that there was a significant reduction and decrease of the purulent discharge and the plaque that was seen at the baseline levels. So this is a view for the palatal, and where we can see as compared to the baseline that how the gingival enlargement is regressing and how now the teeth surface are getting exposed, which enabled the patient to perform better oral hygiene and which enabled us, the clinician, to perform better scaling and subgingival scaling for improving the periodontal outcomes. Now, 6 months into drug substitution and non-surgical periodontal intervention, we saw a huge regression of gingival enlargement and improvement in all the periodontal parameters of the patient. However, there was just a persistent gingival growth that was present in the right maxillary palatal region that was non-responsive, and the gingival enlargement from all the other areas were regressed. Since we usually follow a protocol of waiting till 6 to 9 months after drug substitution to see the regression of gingival enlargement, this non-responsive right palatal maxillary area was then decided to go for surgical intervention. We used the electrocautery considering the bleeding it would involve and the thickness of the tissue. So the entire enlarged localized region of palatal gingiva was excised with the help of electrocautery. Also, considering that it was a young 15-year-old patient and the massive open surgical wound that would heal by secondary intention, injectable PRF was injected to improve the healing outcomes, and we got an uneventful healing at 2 weeks post-surgery. So we kept the patient on regular follow-ups with the 3 months interval. We kept on reiterating the plaque control and maintaining the oral hygiene. And we continued with a non-surgical periodontal therapy of scaling, deep scaling at the regular intervals. And this is what we got at 18 months. So there was a complete improvement of periodontal parameters. There was a regression of gingival enlargement and a very notable finding of the realignment of maxillary incisors. Like in the baseline photo, there was a pathological migration that was seen because of the pressure exerted by the protuberant gingival mass. And in the post-operative at 18 months, we could see that these incisors realigned themselves, mainly because now they got a better equilibrium of forces that led to the reorganization of the transeptal fibers, and the patient's aesthetic, smile, mastication, speech, everything improved. So this is again the palatal view where we can see the complete regression and complete maintenance of good gingival architecture and oral health. This is for the lingual, where again all the enlargement has settled and patient is maintaining good oral hygiene, which is very important because there have a lot of been studies which have shown that this plaque would again lead to high rate of recurrence of this enlargement. But we did not encounter any sign of recurrence at the 18-month follow-up, also because of the meticulous plaque control regimen followed by the patient. So we can also appreciate in the compare the pre and the post-treatment OPG, where we can appreciate this maxillary incisors and their realignment that happened because of the removal of the pressure of the gingival enlargement that led to reorientation of these maxillary incisors. So this is a comparison of the extraoral view, and we can appreciate the mouth closure, the change of profile, and the improvement of the facial aesthetics of the patient. Even the side views, we can appreciate that how initially there was a facial disfigurement and an appearance of a facial asymmetry that was resolved post-treatment. And the important part is that the entire of this larger part of the treatment was managed non-surgically, just with initial few steps of good plaque control and drug substitution, which drastically improved all the periodontal parameters, the severity of the overgrowth index, the reduction in the plaque levels, and improved the bleeding, gingival bleeding outcomes, leading to a very good periodontal health. Now, as we all know, that it is well established that health-related quality of life is an important outcome that is assessed during epilepsy management, an important thing where the patient is holistically managed much beyond just the seizure control. In our case, why this case was important, because here the oral side effects, here the oral effects because of the adverse effect of drug has much outpassed the effect of the seizure. Patient was more perturbed by her daily functioning of mastication, speech, eating due to gingival enlargement rather than having the seizures in her life. So we assessed that with the help of oral health related quality of life, which is a set of 14 questions comparing and including various aspects like functional limitation, physical pain, psychological discomfort, physical disability, psychological disability, because patient had a huge impact on her psychosocial health because of the enlargement. So when we saw that there was an initial score of a 52 out of 56, that is very poor oral health related quality, and just after the non-surgical treatment and drug substitution, it improved from 52 to 15. That is about 70% improvement that made a major change in patient's life. And of course, on the follow-ups, because of the meticulous plaque control and with the altered drug, the patient maintained a very good and highly improved quality of life. So even if we talk about the subscales of this oral health related quality of life, then it is something to ponder about, that at the baseline, as much was the patient affected by the physical pain, same was the psychosocial discomfort and the social withdrawal. As explained by senior resident Dr. Jaya, that patient has completely withdrawn from school, from her peers, not getting involved in any activities. So again, a significant improvement in all the aspects of her oral quality of life was achieved by these non-surgical management of the patient, which was continued. So now I would like to call upon Dr. Anupriyanka to talk more about dental plaque as an activating factor and review of literature.
Good afternoon, everyone. Seeing about the review of literature, as we can see that the first picture is the healthy gingiva. We can see that the gingiva is more firm, pale pink, and we can see. So, and we can see that there are margins of the gingiva are more scalloped in nature. Whereas an enlarged gingiva, we can see that the tissue is more thick, fibrotic, and it is almost cover all the part of the tooth surfaces, making it more difficult to maintain the oral hygiene. Also causing difficulty in the chewing also. So as we grade the enlargement, we have given grade 0, as there are no signs of gingival enlargement in case of a healthy gingiva. In case of an enlarged gingiva, this grade has been given as grade 3, since it has covered almost 3/4 of the crown. So there are various there is various gingival enlargement. The first and the most common enlargement which we commonly encounter in our clinics are the plaque-induced inflammatory gingival enlargement, which is mostly caused because of the local factors like plaque and calculus. As we can see that the gingiva is more swollen, reddish, erythematous with local factors like plaque and calculus. So in these cases of enlargement, we usually manage with the non-surgical periodontal therapy like scaling and root planing, and sometimes it usually regresses after the non-surgical periodontal therapy with the oral hygiene measures. So the other one is the idiopathic gingival enlargement, which could be of unknown causes, or sometimes it could be of a hereditary basis. As we can see that the gingiva is more firm, fibrotic, and also it has covered almost half of the complete part of the tooth surfaces. And this is again a plasma cell gingivitis, which shows a massive enlargement. So these kind of enlargements we usually manage it with the surgical periodontal therapy because it usually does not regress after the non-surgical periodontal therapy. So, however, a drug-influenced gingival enlargement, which is caused because of the underlying drug usage, the treatment mostly consists of a drug substitution and also consulting with a neurologist, along with the non-surgical periodontal therapy with the regular follow-ups. So, in these cases, we have to do a surgical periodontal therapy along with the drug substitution. So, there are usually three kinds of drugs which are given. One is the anticonvulsants, antihypertensives, and the immunosuppressants. So phenytoin, almost 50% of the patients who have been given with the phenytoin experience these kind of gingival enlargement. As we can see that the gingiva is more firm, fibrotic, also covering almost half of the tooth surfaces, and it is more lobulated in appearances. Next is the antihypertensives, which are the calcium channel blockers. Almost 20% of the patients which are given with the nifedipine and amlodipine experience these kind of enlargement. The other one which we give is the cyclosporin, which are the immunosuppressants. Almost 30% of the patients experience these kind of enlargements, which are more of vascular in nature, red erythematous and vascular in nature. So, coming to the phenytoin-induced gingival enlargement, since we discussed this as a case presentation today, so we can see that the gingiva is more lobulated, enlarged, almost covering all the tooth surfaces. The enlargement is so massive. So, coming to the prevalence part, it almost affects 50% of the persons who are taking with the phenytoin. So, coming to the dose-related risk, various studies have shown that dosages as low as 6 to 8 milligram per kilogram per day have been reported with the gingival overgrowth. And it has been said that higher daily doses increases the risk of the enlargement. Although there is no fixed threshold, there is some individual variations. And according to the oral hygiene measures the patients follow, there might be some difference in the enlargement. So, coming to the resolution after the discontinuation of the drug or a substitution of the drug, a noticeable reduction has been seen in after 1 month, although a full reversal takes up to 6 to 12 months. So, coming to the pathogenesis part of the phenytoin-influenced gingival enlargement, so we can say that it is of a multifactorial pathogenesis. There are various factors which is going to impact the enlargement part. Dosage, either the duration of the drug, type of the drug, oral hygiene measures followed by the patient, or an individual genetic susceptibility, all contributes to the enlargement. So the first most important is because of the reduction in the uptake of the folic acid into the cells. So because of that, there is going to be limited production of the collagenases, because collagenases are responsible for the degradation of the collagen enzyme. Because this has been decreased, there is going to be an increased production of the collagen and extracellular matrix deposition. So the other important pathogenesis could be because of the heterogeneity of the subpopulation of the gingival fibroblasts, and also combined with the local factors, plaque, which is going to act as an important cofactor. So because of the plaque-induced inflammation, there is going to be production of inflammatory mediators like interleukin 6, interleukin 1, and interleukin 8. Because of that, there is going to be a proliferation of the T cells and also recruitment of the inflammatory infiltrates. So dental plaque, which is acting as an aggravating factor, as we have already seen that it is not only because of the phenytoin combined with the local factors, it is going to aggravate the situation, worsen the drug effect. So we can see that the plaque-induced inflammation is going to increase the vascularity, enhances the inflammatory cell infiltration, increases the cytokine productions, which in turn stimulates the fibroblasts and causes extracellular matrix deposition, leading to massive gingival overgrowth. So now Dr. Vikendra sir will be taking up with the summary part and he will conclude the lecture. Thank you.
As I said in the beginning that the case was treated by the most conservative means, and as you saw through the presentation that the case healed well with non-surgical periodontal therapy and drug substitution only, except for a surgical periodontal therapy only on one part of the mouth, that is the palatal area. So this case highlights the importance of collaboration between the treating physician and the periodontist. And as the patients who are on anticonvulsants are regularly monitored by their physicians for the episodes of the seizures or the recurrence of the seizures, the treating physician they should also consider for referring them to the periodontist for the evaluation of the oral health or for checking the onset of the gingival enlargement if there is any, because once the gingival enlargement sets in, the oral hygiene performance by the patient is compromised, the plaque control is compromised, which ultimately leads to the superimposed gingival inflammation, and then a vicious cycle sets in. So therefore, it is very important for the neurologists for referring the patient to the periodontist. Likewise, for the periodontists also, when they see any case in their OPD who is under drugs which can cause the gingival enlargement, that they can consider sending them to the treating physician if possible for the replacement or the substitution of the drug whenever possible. So I think this was the good case to highlight the importance of the collaborative work, and I think that should be done for the best care of the patient. Thank you. Any questions we are open for? Yeah, neurology here. Yes.
You mentioned that people develop a gingival hypertrophy. What proportions gross morphology will be? This is interesting thing with such a gross morphology.
Yes. That's a nice question, sir. Actually, the severity you mean to? Yeah. Severity, actually, although there is no linear relationship between the dosage of the drug and the severity of the enlargement, but when the patients are already have poor oral hygiene, or they are not able to maintain, or they are not maintaining their oral hygiene, that is superimposed to the drug adverse effects of the drug. And phenytoin is one drug that is known to cause gingival enlargement. So that's why I reinforced on the importance of the collaborative work, because when the gingival enlargement is there in the initial steps, then at that stage, if it is possible for us to substitute for the drug, then it would be good. And at the same time, we can reinforce the patient for maintaining the oral hygiene and regular periodontal or the dental checkups. So all these things, they are related to each other. So this is not only the factor that the drug caused this. So it's a combination of several things. So because once the enlargement is there, patient is not maintaining the oral hygiene not maintaining it, there is inflammatory gingival enlargement, and when the patient is not able to even close her mouth due to enlargement, due to mouth breathing, and there is dryness of the gingiva, enlargement then again accentuates. So all these things are interrelated.
I also add little bit to it because I teach children and children do have more tendency. Uh, about 20 years back when we were teaching children, that time we used to get more gingival hyperplasia in children. But nowadays, because of the awareness, we get lesser number with gingival. And the same issue, one of my colleagues, when I was doing post-graduation, my colleague did a study to find out what are the other factors. One is oral hygiene, well known, and the drug effect, well known. But the folic acid, which was mentioned here, supplementation of folic acid reduced it significantly. So, improved nutrition has also changed the spectrum of this disease over the period of time. Can you tell us what makes it so specific that these drugs they cause only gingival fibroblast to act? the other body sites are not impacted.
So I'll just take up that question. So the very clear-cut mechanism is still not elucidated. We have some proposed mechanism which says that the metabolite of phenytoin, the gingival fibroblasts are very sensitive to it. So some patients, they have that sensitized population of gingival fibroblasts. Because of that, they cause an exacerbated response. There is a imbalance of the collagenase enzyme which happens, the matrix metalloprotease that are responsible for the degradation. So there are various factors that will predispose. One is the genetic heterogeneity of that gingival fibroblast, or sensitivity of that gingival fibroblast, that they particularly that metabolite of phenytoin that targets.
Maybe the explanation, but microblast, I believe,
And then the
similar,
other also,
similar.
Yes.
There also there may be certain other factors apart from hypersensitivity of gingival
And so
fibroblast
another,
and the drugs.
yes, sir. And the another thing is that because of the open environment,
Yeah.
that phenytoin, there is an increased absorption. And because of the, like if there is inflammation also because of the increased vascularity, and through gingival crevicular fluid also, there is more absorption of the drug in the gingiva that starts this cascade.
Then second, you show three categories like antiepileptics
Yes.
and calcium channel blockers and cyclosporine.
Yes.
Is there any morphological difference? If they look very different clinically, are they different morphologically, and pathogenesis is also different between these three groups, or they are very similar?
Clinically looking, there is difference.
You mentioned it for phenytoin very specific. It is very lobulated.
Yes, sir. So the first group are the anticonvulsant drugs, which we just discussed about. And it is the last picture where there is cyclosporine on the immunosuppressant influenced gingival enlargement. The cyclosporine induced gingival enlargements, they are relatively more vascular than the phenytoin induced, they are more fibrotic. So clinically appearing, there will be more bleeding on probing or even on brushing from patient point of view in immunosuppressant induced gingival enlargements compared to phenytoin or amlodipine induced gingival enlargements. So that's the difference in the morphological characteristics of the gingival enlargements. And the second question was about the